All right, moving right along to part 3. The secondary exam is much the same for a pediatric patient as it is for an adult. The full secondary exam of the body is used when a patient is unresponsive or has a significant mechanism. This is where you're going to use DCAT BTLS and check the entire body. We've been practicing these. You guys know how to do these. The focused assessment is done on patients without a major life threat with specific complaints and are usually isolated to one central location of their body based upon their complaint, their mechanism, their nature of the illness, and any findings that you had on the primary. Infants, toddlers, and preschool-age children, as I told you, should be assessed from the feet and moving up. School age and adolescents should be given a top-down or head-to-toe approach. Okay. You're going to assess all of these areas specifically. You should be doing these on all physical, on full secondary exams anyway, but make sure that you are assessing the head, nose, ears, mouth, and neck, along with their chest, back, abdomen, and extremities. This is a whole body assessment. Vital signs. So, some of the ways that we normally assess an adult for their circulatory status have limited use in a pediatric patient. Again, know your vital signs. Consult the chart in your book to determine whether or not the vital signs that you're getting off of a patient are normal for them. If it's not, that is a sign that something bad is happening. If it is, we can usually move on. Generally, we do not assess blood pressures in patients younger than 3 years of age. So they're very difficult to get, they're kind of unreliable, and it's generally not as big of a deal as their skin signs, their respiratory rates, their pulse strength, things like that. Like I said, skin is your friend. Assess their skin, assess their fontanelles, assess how they're breathing. When you are using equipment, make sure that you're using the correct sized equipment. Make sure that you're not using a blood pressure cuff that's too big or too small for whatever age patient you're dealing with. It should cover the upper 2/3 of their arm, and no more, no less. For blood pressure, use this formula, and you guys need to know this for children ages 1 to 10 years old. It's 70 plus 2 times the child's age in years. So if you have a 7-year-old patient, 7 times 2 is 14, which means their systolic blood pressure should be about 84 millimeters of mercury. Okay, this is for their systolic, their top number of their blood pressure. Okay. You want to count respirations for at least 30 seconds on these patients. Anybody younger, you can assess their respiratory rate simply by looking at the rise and fall of their abdomen. Remember, they breathe from their diaphragm, so they're belly breathers. So looking at their abdomen will give you a nice, easy way to count their respirations. So again, pulses at least a minute in length. Okay, respiratory rate was at least 30 seconds. Pulses are at least a minute. That'll give you their full heart rate at that point. They can be harder to palpate. You can also choose to auscultate the chest and count the heartbeats if that is what you need. You usually assess your respirations, then pulse, then blood pressure. You can still evaluate the pupils. We're still checking to make sure that they're pearl, they're equal, round, reactive to light, and equally reactive to light. And a pulse oximeter will still work on a pediatric patient. So, just like with an adult, we reassess every 5 to 15 minutes depending on their stability level. Continue to monitor their vital signs, look for trends, look for changes in their LOCs, look for changes in their AVPU and GCS status as well. If you do have to give any interventions or re-administer things, use their parents and caregivers wherever possible. Use good therapeutic communication and good documentation because it will be a big deal to the hospital to know what you've done and at what time you did it. See, this section wasn't so bad. I'll see you in the next one.